using genotype anti-DDR plus assay.
Hello, I'm David Chkranino. I work in the National Center for Tuberculosis and Lung Diseases in Tbilisi, Georgia. This presentation concerns the molecular diagnostic method genotype anti-DDR plus in patients with suspected TB. And in the end of the presentation, I would like to show you some cases of airway stenting and endobronchial laser resection performed for the first time by our team in Georgia. The global burden of tuberculosis still remains enormous. WHO reported last year that Eastern Europe has the lowest TB treatment success and highest MDR, XDR TB rate in the world. And Georgia is among 18 high-priority TB countries. Incidence of tuberculosis in Georgia is 123 cases. In absolute numbers, it's 5.5 cases, and it's important that multi-drug resistant tuberculosis increased to 475 cases in 2011. The diagnosis of tuberculosis depends on the isolation and identification mycobacteria in sputum, and control the multi-drug resistant tuberculosis depends on high sensitivity results. However, drug susceptibility testing by conventional culture for mycobacteria is slow and takes several weeks. And during this period, patients may be treated inappropriately. And this method, PCR-based anti-DDR plus assay, enables the rapid detection of MTB complex in sputum and rapid sensitivity results. The genotype anti-DDR plus is based on the DNA strip technology. Mycobacterial DNA is extracted from the specimen and detected on the membrane strip using the reverse hybridization and color enzymatic reaction. This test system enables simultaneous detection of the MTB complex and its resistance to rifampicin and isoniazid, two most important first-line antituberculants. We have selected patients unable to produce sputum and with sputum sample negative. And total 33 blood samples were examined. 18 patients didn't produce sputum and 35 were sputum smear negative. So interestingly, the failed patients without sputum production began to produce after valve procedure, and 4 among them appear to be sputum smear positive. 23 samples were culture positive, and as you can see, the patients admitted to us has a different preliminary diagnosis. Among 23 culture positive cases, valve PCR was positive in 70 cases and negative in 6 cases. Relatively, valve smear was positive in 9 cases and negative in 14 cases. In culture negative 30 cases, both the valve PCR and valve smear was positive in 2 cases, false positive cases, and negative in 28 cases, true negative cases. As you can see, the different sensitivity between valve PCR and valve smear is evident. The specificity is the same. For us, as for practitioners, most valuable this method was in complex cases, and I would like to show you some of them. First one, 68-years-old male with a medical history of 20 days. He complains fever, weakness, weight loss. His condition was severe despite the long-term antibiotic therapy. His initial diagnosis was abscess. And we performed bronchoscopy and genotype anti-DDR plus assay detected the MTB complex in valve. In this case, valve smear was negative. And we included, this patient was included in national anti-TB program. We started anti-TB treatment, and after 1 month, finally his condition started to improve. Next case, patient, 18 years old male with 1 month of medical history. His initial diagnosis was lymphoma. He complained of intense pain in the left chest. We performed bronchoscopy and diagnosis with TB. Anti-PDR class SA detected the NTB complex in BAF. We started anti-TB treatment, but after 2 months of treatment, anti-TB treatment, his condition worsened. And we had suspicion of misdiagnosis, but repeated bronchoscopy revealed occlusion of left lingular bronchus by calcareous from the bronchonodular fistula. And TB diagnosis was confirmed also cytologically. He continued treatment and now he is in good physical condition. This study shows that BALF procedure contributes the appearance of sputum. Combined use of BAL smear and anti-PDR class SA has a good diagnostic yield in complex cases. This method may be suggested for wide use. At this moment, the gold standard is still the culture, and the other methods have to be considered and interpreted as complementary diagnostic methods. And finally, as I mentioned in the beginning, I would like to present you some bronchoscopic techniques performed for the first time in Georgia. We were inspired for this by the first Congress of Bronchology and International Pulmonology in Marseille. And after this Congress, we pioneered the introduction of advanced bronchoscopic methods in Georgia. This case of airway stenting in cicatricial post-TB bronchial stenosis, a 24 years old woman, after completion of anti-TB treatment, she developed cough, dyspnea, wheezing. On this chest X-ray, the left lung is hyperventilated and the diastema is shifted to the left. Under general anesthesia, we inserted balloon expandable metallic non-powered stent, and after stenting, the diastema returned to his original position. Here is shown that contrast freely passes through the right main bronchus and doesn't to the left. And after stenting, the contrast passes equally in both main bronchi. Another case, this is case of laser resection in basal cell adenoma, 39 years old male. The CT scan showed occlusion of the left main bronchus. During this bronchoscopy, we performed biopsy, and which revealed the salivary gland-like tumor, basal cell adenoma. 1 month and 1 year after laser resection. After 1 year, we performed biopsy from a suspicious place. Cytologically, no significant changes, and we were waiting for the result. We are waiting for the results of molecular examination. We used a surgical diode laser system. This is a removed tumor. And another case of laser resection, 52 years old male, 1 month of medical history, chest CT with subpyramidal tissue mass that completely blocked left main bronchus. On the CT scan, you can see atelectasis of left lower bronchus. And here is shown left main bronchus blocked by a tumor. The right upper lobe also was treated by a tumor. We used the diode laser system, and step by step disintegrated the tumor. This tumor was surface of this tumor was bleeding. And now the patient is undergoing chemotherapy, and we planned stenting. This is hemostasis authorization. We planned stenting, and we were prepared to wait. Thank you for your attention.
Thank you. Any question?
Is it bal bronchoalveolar lavage?
Yes,
Or
we use 100 saline.
How do you protect yourself by doing the taking part?
Tavsiye itself.
Tuberculosis patient because
Tavsiye itself.
You mean the patient is given?
yes.
I do mask.
We use a mask. We
And
performed bronchoscopy in TB patients every day, on average 10 to 12 patients. I work 20 years in TB area, and it's great.
We are working like you in sanatory 20 years, and I saw all my doctors, friends, they are tuberculosis patient from bronchoscopy. They take
Maybe,
all,
but
you are studying with multi-drug resistant tuberculosis patient.
yes.
The other problem is maybe contamination from the bulk.
You know, we don't know this. We performed in diagnostic cases. We do not know this is multi-drug or is it tuberculosis or no. I show you different initial diagnosis. We don't know this is tuberculosis or not. In our case, only 2 patients have resistant tuberculosis, not more. It revealed this method, genotype and TBDL plus assay that I showed you. Only 2 cases among 53 cases were multi-drug resistant tuberculosis. But other cases, no multi-drug resistant. You understand that? This is for differential diagnostic cases. You are right. We don't force this procedure in multi-drug resistant patient if it's not very necessary. We don't perform in multi-drug resistant cases, but in diagnostic cases,
These patients have no sputum, that's all you take bronchoscopy, yes.
or without sputum or with sputum smear-negative cases. When depending on their diagnosis, this method will help us.
Sorry, one comment if it's possible.
Yes.
We are from Georgia and National Center on Tuberculosis and Lung Diseases, and we have a great practice. It's also in first Congress when we were.
Please take
Okay.
the microphone.
Don't want to stay back. That's why. And when we speak about the tuberculosis, everybody became afraid of the same because we have the great process of cancers and other diseases, but in countries of post-Soviet Union, it's a problem. Everybody knows about this, and we have a very great practice of not only to bronchology manipulation in this process, but also thorax surgery situation for tuberculosis. And we have a very great practice. For example, it was very easy when we are listening to fistulas, bronchopneumonia, and such a thing. That's Georgia is one of the leader of the region to make this, because in Georgia are treated patients from near republics, from south of Caucasus, from Armenia, Azerbaijan, and such a things. And also we have the very good trainings with our Turkish colleagues, and from 6 to 9 June in Georgia, in Batumi, we have the same conference from these problems with our Georgian Respiratory Association and Turkish Respiratory Association. Thank you for your attention.